Good evening, everyone. We're so excited you have joined us again this evening. Welcome back. This is our first webinar this fall, and we're so excited to have you back. I'm Dr. Edith Bracho Sanchez. I am a primary care pediatrician here at Columbia, and I also lead our external affairs team. I have an amazing group of panelists with me this evening to talk all about navigating the school season ahead. While we give everyone a minute to join, I just want to remind you that we are on social media. You can find us there for updates on events coming up, to hear from our experts. We actually need to update this because we used to be at Kids at Columbia and we have changed it to Columbia Pediatrics. Breaking news. So you can find us on social media at Columbia Pediatrics. We also have a newsletter that goes out every month with updates from all the things happening at Columbia Pediatrics that you can sign up for, and we'll send you the link. If you are commuting or doing something that prevents you from scanning this code right now, do not worry, we will send you this. We also want to remind you, and we sent out an email, but just to mention it briefly, that this December, we're having the 12th annual Pediatric Specialty Updates for the General Practitioner. It will be from December 6th to the 7th. It is a virtual conference. Very, very exciting, very good updates from amazing, amazing practitioners. And the recordings will be available for 3 months after the actual meeting. So if you are busy that weekend, do not worry. The recordings will be available as long as you register. So please go ahead and register. And again, we'll send you the link to register after this webinar. And last but not least, in terms of updates, the one just opened in Westchester. We're very excited. It is in White Plains. All of our specialists are up there now. So Westchester families and pediatricians who are referring those families don't have to come all the way to the city to see our amazing specialists. We will be sending you that website as well, which has this phone number where you can call, and more details on the specialists available, and a small but growing primary care footprint up there in Westchester. So very exciting. Okay, let's get to today's agenda, which is all about navigating the school season ahead, specifically when it comes to new vaccine recommendations, respiratory season, school policies, and so much more. To talk about it all, I have with me Dr. Melissa Stockwell, who is a pediatrician and the chief of the Child and Adolescent Health Division. She has so many other titles, including working at the School of Public Health, where she also has an appointment, and she's, very well known vaccine researcher. We also have with us Dr. Candace Johnson, who is a pediatric infectious disease specialist, hospital epidemiologist, and also many, many other titles. And Dr. Amanda Estevez, who is a primary care physician and is on the ground having conversations with our families every day. We're so excited to have you all. Welcome. I'm going to stop sharing my screen for a second so I can see you all a bit better, if I can figure out how to stop sharing. And give me just a moment. And then a very quick disclaimer that the content on this webinar is provided for general information only. All right. All right. So let's start with you, Melissa, if it's okay. I think the question that is top of mind for all of us is, what are the vaccine recommendations for this fall and winter, and how have they changed recently? Because it seems like there's a lot happening.
Absolutely. That's a great question. I'm going to start with the more straightforward ones first. So just like in every other year, there's the annual flu vaccine. And I think it's already available at pharmacies and practices are getting it. That's an annual, everyone knows, an annual vaccine. Some kids who are through the age of 8 might need 2 doses, depending on if they've gotten 2 doses in a previous season. Put that one aside. Actually, the only difference in that is it's now only a trivalent vaccine. This is sort of interest. So we had a number of years ago added a second B strain. We were a quadrivalent vaccine. We actually have not seen that strain, the Amagata strain, since the pandemic basically started. So in 2020. So that's been now taken out. So new vaccine formulation, trivalent. That's straightforward. remind everyone about RSV. So all of our babies, their mom got vaccinated during pregnancy. They don't need it in that index pregnancy. They don't need it this season, but otherwise, starting October 1st, someplace in New York, particularly in Brooklyn, might be starting a little bit earlier because there's a tiny increase in RSV there potentially. But generally October 1st, making sure that we are getting the RSV monoclonal antibody for our infants who are less than 8 months old. And then for the little bit older kids, if they have a particular one of the few very high risk conditions that would make them need it in their second season. I think people are pretty familiar now with nirsevimab now that we've a few seasons under our belt, and better supplies than there were in previous seasons. There's actually another new monoclonal antibody that's going to be coming out, but I think we won't touch on that for right now. So on everyone's mind is probably COVID vaccine. There's been a lot of information recently. Just going to put a little asterisk that we don't know how recommendations might be changing coming forward. What I will say is that we luckily live in New York State, and New York State and New York City have actually come out with their own COVID vaccine guidelines, which for pediatrics align with the American Academy of Pediatrics. So that's what I'm going to review for you right now. So first is the kids who are 6 months to 23 months. Those are our kids who are at our highest risk of more severe illness for COVID. And it's recommended that all of those kids get COVID vaccine. Obviously, if they've never gotten a dose, you're going to do the complete series. If they have started and did finish, you'll finish it. Right now, as you probably had heard, that the FDA did not end up moving the Pfizer vaccine from, they canceled the emergency use authorization and didn't license it. So it's going to be Moderna is going to be the product that we have for that youngest age group. Then we have the kids who are 2 through 18 years of age. For those kids, particularly those who have any condition that puts them at high risk for severe COVID, I want to recommend to vaccinate them. Any who have never been vaccinated, vaccinate them. Any that live, in a residential or congregate setting, and then anyone who lives with someone who themselves are at high risk of COVID. That's that second group of the 2 through 18 who are either at risk or low risk or at risk. And the last group is a really important group, which is any parent who wants their child vaccinated against COVID. We should go ahead and vaccinate their children. This again is maybe different in other states, so I'm kind of staying right now to New York State. And that's because New York State has its own recommendations in terms of what's being covered. They did also send to pharmacies a non-patient specific standing order, which allows them to vaccinate for kids who are, I believe, 3 and older against COVID vaccine. And then the final caveat for that last group there is, and we'll get this a bit later, is we do know that while COVID can be mild, it can also be severe for particular age groups, but there is also long COVID. I'm going to touch on it later in the webinar, but just there are lots of reasons to vaccinate other than severe disease. So
yeah, I mean, and just a reminder for everyone that you can put your questions in the Q&A. We'll get to some of the questions as we go. We also have some time at the end to answer some of the questions. So Melissa, just to recap, the 6 month to 23 month, there is a strong recommendation from the AAP to go ahead and vaccinate against COVID-19. And the product that is available is Moderna vaccine. And then above that, kids whose parents want them vaccinated, who have a high risk condition, who live with someone who is high risk. And I guess my question for that age group, it sounds like no, but I want to make sure. Do parents of those kids need to show up to the pharmacy with a prescription, or are they, if they're not, I should say, if they're not able to get vaccinated at the pediatrician's office, which sometimes happens, right? Not all pediatrician's offices are stocking this. So if your pediatrician's office does not stock it and you want your child vaccinated, what are the steps, Melissa?
Sure. I'm going to say you should always call the pharmacy first because, just to make sure your local pharmacy has it and will give it. But what's nice about if you're in New York State, again, I know sometimes people are calling in from other states, and if you're in New York State, because the Department of Health put a standing order for kids who are 3 and older, you should not need a prescription from your doctor to be able to get the vaccine. But as I say, you should call the pharmacy, double check, make sure it's correct. I do know that because I was looking for my own kids who are actually all getting vaccinated tomorrow. I think some of the pharmacies will have this question about like, do you have a high risk condition or not? So not all the pharmacies, particularly the large ones, may not have state specific like online scheduling. And so just again, call, make sure if they say they need a prescription, to say, well, actually, my understanding is that New York State has given a non-patient specific standing order, but you should be able to go and get it.
Fascinating. Well, so we also had a question that came in that says, can you review the complete series for COVID-19 in infants? So what does it mean at this point to
Mhm.
complete your primary series, I believe is the
Yeah.
question.
So it's a little bit different for Pfizer versus Moderna vaccines. So for Pfizer, it was actually 3 doses to complete the series. For the Moderna vaccine, it's just those 2 doses. So it depends a bit on honestly, I usually tell people to look online because it depends on the kind of combination of previous doses that a child got. If you have a new infant coming in, and you were giving Moderna, you would give those 2 doses, and that would be a complete series for them. If they had Moderna before, you can give another one now again to complete the series.
Got it. And Melissa, before we move on, and I do want to go to Amanda next to hear about what's going on the ground, really, because I think there's been questions, there's been confusion, which is part of why we're doing this. But this particular season, as you know, this summer there was a report that showed that vaccination rates in kindergartners have continued to drop in recent years. Just briefly, I would love for you to put that write that report into context and tell us why we care about that measure specifically and what the concern is around back to school season. And here we're talking more broadly, not just, the COVID-19 flu and RSV vaccines that we just talked about, but more broadly. So what is the concern, Melissa, and why do we care about that?
Sure. So we talk a lot about infants and infant series and vaccinate. We think about like the HEDIS, particularly primary care doctors, the HEDIS measures if we're looking, for quality. Another really important indicator are those kindergarten shots, right? So the shots that we're expecting to give, for usually age 4 to 6, and a lot of the kindergartens, want that for entry. And it's another marker that we look nationally to sort of take the pulse of vaccination rates and vaccine hesitancy across the country. And so the concern with that rate falling is it an indicator that we're having potentially some more vaccine hesitancy across the country? And why I think most states have requirements for school is because the best thing about school is lots of kids together, playing and doing all the things that we want kids to do. But as Cece will say, as an infectious disease doctor, right, that's a lot of potential people. If one person is sick, has measles, for example, where they really could have transmission in that setting. And so we really want to make sure that all the kids that are going to school are protected by being vaccinated. And so that's like a really important marker that we look at across the country.
Yeah, so important. So, Amanda, as a primary care physician on this panel, who is counseling families every day as they head back to school, I'm curious to know, what are you seeing and hearing in terms of attitudes toward vaccines, and what questions are families asking you this season?
Yeah, absolutely. I think parents are just really confused. I think there's just so much messaging and so much content in the media in various locations that they're seeing that is contradictory to one another. And parents are just honestly very confused. I feel like, anecdotally at least, I used to have these conversations maybe once a week, maybe a few times a month, and they are absolutely occurring daily now. I constantly get parents saying, "Do I really need this? Is this required? I didn't think this was needed for school anymore." And so it's just a lot of understanding where they're getting their information from, what it is that their fears and concerns are, and really trying to meet them where they are and reassure them and continue to practice the way we have been.
Yeah, it really is just taking additional time, right? Whereas in the past it felt like a bit more of a straightforward conversation, and now it's more of a, more in detail, more in depth, which is not necessarily bad. I think just things are changing, right? Stacey, tell us, and again, you're the infectious disease specialist on this panel, and you're also a hospital epidemiologist. So I do want to ask you about the respiratory season ahead. So, of course, every respiratory season is unique. I just wonder if you can share what we know going into this respiratory season. I wonder if there's current predictions for flu, for RSV, for COVID, knowing what's been circulating this summer.
Yeah. No, that's a really great question. You are so right. Every respiratory season is unique. And so there's no, absolute perfect predictive model, but we do have a lot of data that we can draw off of. And there's national surveillance data that we're able to look at to kind of assess the trends and looking back what the trends were last year and actually what happened last year and using that to kind of inform what we expect to see this year. And so thus far, based on that available data, there's nothing to indicate that this season is going to be dramatically different or look dramatically different, like overall from a respiratory viral season than last season, but there are definitely caveats to that. And so you kind of mentioned the big three that we're talking about today: flu, RSV, COVID. And so if we kind of break those down, for all of them, we know that generally this fall winter respiratory season is like October through May. When we think about the flu, again, we have the information that we had from 2024-2025 flu season, and that was actually considered to be a high severity season. And so when we think about severity for these viral infections, typically the marker that we're looking at are rates of hospitalization. And so last year we saw higher rates of hospitalization for flu. And so knowing that and kind of looking even broader over time historically, the positive is while last year was a rough year, historically, we haven't seen like consecutive high severity flu seasons. And so again, we can't predict exactly what this flu season will look like, but the expectation and the hope is that it won't be as severe as last season was when we think about, again, those hospitalization rates for influenza. When we think about RSV, we've talked a little bit about kind of the protective measures that are now in place for RSV, the fact that we are able to immunize our highest risk population, our infants, our pregnant mothers, to protect those vulnerable infants, and our older adults. Last year, thankfully, we saw a response to that practice. And so we saw decreased rates of hospitalization due to RSV. And so again, the expectation is that that trend will continue, which is a good thing. These are effective therapies for our patients. And then there's COVID. And so when we think about COVID, you mentioned what's circulating in the summer. Certainly we are seeing COVID circulate in the summer. So it is kind of an outlier when we think about these respiratory viruses. It's not contained just in this fall winter season. And so we actually do tend to see kind of a peak in the summer. And so that kind of tracks with the numbers we're looking at right now, where we saw kind of end of July, August, numbers trickling up. And then we have our winter peak as well. And so knowing even the summer data helps us as we think about the winter ahead. And so last year, compared to last year, the summer numbers that we're seeing lower rates of hospitalization due to COVID over the past couple of months compared to this time last year. What that means, so as we think about what's coming in the winter, is that we actually may see higher rates of hospitalization than in the winter because we're going into the winter season with fewer people who have seen the more recent circulating strains of COVID. And so there is that risk factor that's there. And so when you put all of that together, kind of the ups and downs of each of those viruses, again, big picture, the expectation is that the season will look generally similar. Again, with those nuances. So hopefully less flu hospitalizations, but we may see more COVID hospitalizations.
Yeah, so interesting how you sort of take it all and put it all together as you make some predictions. Again, knowing that predictions are predictions heading into respiratory season. We did have a question come in, Cece, that asked, what was the hospitalization rate for COVID-19 last season? And I think this gets a little bit at, severity and all of those things. But I think if you know off the top of your head, do you remember the hospitalization rate, especially for children, I think, for COVID last season?
I don't have a pediatric number off the top of my head, but let me look into that and I can get back to it because that is an important question.
Yeah, and it's, just to go back to Melissa and things we were talking about before, right? It's the the general thinking, especially for the general public about the severity of COVID-19 has evolved, right? Like it's, I think that's the best word I can use to describe it. It has evolved as we've learned more information, as there's been, unfortunately growing mis and disinformation online. So I think just to talk about this for a second, you study COVID-19 in children. You study long COVID specifically. How does what does the data show about how serious COVID-19 is in children, and how common long COVID is?
Sure. That's a great question. Um, so I think, for most kids, right, COVID infection is going to be a mild infection or a or short-lived respiratory infection. Um, but there was sort of this misperception early on with COVID that COVID would always be mild. We clearly know that's not true. And as CC mentioned, right, we know that particularly those young kids and the kids with chronic conditions can be quite at risk for much more severe COVID. There's also this misperception, or there was misperception that kids can't get long COVID. So what is long COVID? Long COVID is a chronic condition, it's an infection-associated chronic condition that occurs after a COVID infection, and usually occurs usually start within about 3 months of an infection, and then if they've lasted longer than 3 months, then we're sort of kind of getting into this chronic condition. There's a number, so many different symptoms potentially, and that's because there are probably a lot of different mechanisms that lead to long COVID. And one important thing, just to time aside, is it's not necessarily the symptoms that someone had during a COVID infection continuing. Sometimes that's the case. Often, actually, kids get better, and then these new symptoms evolve. We don't have like great estimates because there's a lot of the studies that were sort of these cross-sectional studies of what the incidence might be. It's probably about 2 to 10% of kids who've had a COVID infection can have long COVID of some kind. And there's been about 65 million kids in the US who we know from like prevalence studies across the country. So if you think even about like 2%, that's like over 1 million kids who have or have had long COVID. And that's much higher than many of the chronic conditions that we see. And so again, this misperception that kids can't get long COVID, we know is not true. The other misperception is that long COVID in kids will look the same as adults. We also know that that's not true. And a whole different webinar we could have on long COVID and what it looks like in kids. I do encourage people to kind of look up some of the symptoms that we are not missing in our kids. And the last misperception is that kids will always get better. And unfortunately, that's not necessarily true. Many do, but many have persistent symptoms and really affects their being able to go to school and play and be with their friends. And there is good evidence that long COVID, that COVID vaccine can help protect against long COVID. And so there's another reason to get vaccinated other than just the acute infection.
Yeah, no, absolutely. We had a couple of questions come in related to long COVID, Melissa. The first question was, does chronic disease from long COVID, so does developing long COVID mean that a child could now have autoimmune disease such as scleroderma, lupus, etc.? So have you seen autoimmune diseases develop as part of long COVID, or what is the data around that?
So that's one of the things so I should say this aside, I'm part of this big NIH consortium initiative called Recover. And so we haven't looked at that quite yet in Recover. So usually long COVID symptoms, the common ones might be headache, fatigue, is something called post-exertional malaise, which actually is in adults also, which is after, pretty low activity, so physical or mental activity, just really feeling like, as if the next day, as if someone had run a marathon and not kind of feeling refreshed after resting. Some of the young school-age kids actually have GI symptoms. There's other kids who have pain syndrome, so a lot of joint pain, headache, back pain, but go to rheumatology, their joints are fine. There's really no known for it. So that's only a couple of the symptoms that we see in long COVID. There are also other potential long chronic conditions that can get kicked off by a COVID infection. So diabetes is one of them. We're starting to see this kind of increase in diabetes after COVID infection. And there are people who are looking into whether there's an increase in autoimmune disease from the COVID infection, which is a little bit different than long COVID, which are sort of these kind of constellation of symptoms that we're seeing that, again, occur after a COVID infection, but are really kind of can affect many parts of the body. And I should actually mention brain fog. That's obviously one of the most common ones besides the fatigue.
Yeah. So what you're saying, Melissa, is like it triggers like a COVID-19 infection can trigger other conditions that the person didn't previously have, such as diabetes, and we're looking into whether it can also trigger other autoimmune
Right, so that's sort of one piece of it. And then for the mechanism of long COVID itself, we're still trying to understand what that mechanism is. There's a lot of really very smart people looking into it, and there's probably there are lots of probably different mechanisms. So there's chronic inflammation, there's people who are looking into viral persistence, whether there's areas in the body where the virus still is that we just aren't able, our immune system and medication really isn't able to get, and that's kind of causing this kind of chronic disease. There's people looking into reactivation, so other diseases that CC may be seeing, EBV, for example, whether it's reactivation. So there's a lot of people, I'm just mentioning a couple of different mechanisms potentially for long COVID. And it may be that some of the different symptom constellations we're seeing may be actually from different mechanisms.
Yeah, so interesting. The other question that came in is whether later strains of the COVID-19 virus have produced long COVID at the same rate as the original strain, knowing that we don't quite know the current circulating viruses. Has there been a difference, Melissa?
We do still, so unlike MIS-C, so for example, for MIS-C, which is the multi-inflammatory condition or childhood syndrome, that really we hardly see anymore. CC, you saw
the very severe complication.
Amanda was working in the hospital at that time. We really saw that primarily with the original strain, a little bit after, but we just really don't see that anymore. We do still see new onset cases of long COVID. And so it is still very much something that children even getting infected now can be at risk for. And they also may be at risk, the infection was mild or asymptomatic, which is also often a question people ask as well.
Okay. All right. And then we had a question from a provider who wants to counsel their families, their patients more about the protective effect of the vaccine when it comes to long COVID. So can you talk about the data a little bit more there so that this provider can counsel effectively?
Sure. There's actually a really good paper that came out in pediatrics from the electronic health. There's a cart of Recover that's looking at electronic health records, and they just about a year ago, a really great study looking at the protective effect of COVID vaccine against long COVID. And I think there's sort of different pieces. There's the piece of preventing infection, but there's also a piece of, even if you're infected, being able to have protect against it long term. And there's a few studies in kids, there's many more studies in adults. And so when I talk to patients and for my own family and myself, my husband and my kids, that's very much on my mind, because having seen really the suffering that kids have and adults have with long COVID, it is very worth it to me for many reasons to get vaccinated, but that's one of them. Anything I can do to potentially decrease that risk, to me is one worth taking.
Yeah, maybe we can send out that study and the recap from today for people who want to take a look. The last question I had about this, and definitely keep sending us your questions. I think it definitely makes the conversation more applicable to what you're actually seeing on the ground and what you're actually wondering. So definitely send us your questions. But I wanted to ask you, Cece, how you have been talking about COVID-19 and severity to families, knowing that you've been in the hospital, in the front lines since the beginning of the pandemic. So, how are you talking to families about it? And how is that conversation being received?
Yeah, and I think for me, it's really been about finding this balance, right? Of offering the reassurance that, as Melissa was just talking about, we haven't seen severe COVID in children in the way that we've seen it in adults, but at the same time, balancing that with the reality that there still are kids that will develop severe COVID. And I think my view is a bit biased because when I see COVID, I'm seeing it in the hospital. So I'm seeing those severe cases. So I completely acknowledge upfront my bias when I think about COVID in children, because those are the cases that I see. But in seeing that, that does inform my conversation with families when I'm talking with families, even about the COVID vaccination and the importance of it. And it simply is just because of that. Low risk is still not no risk. And anything that we can do to protect our children is really important. And because I have seen these children come in with severe COVID in our ICU on a ventilator, anything that we can do to decrease that risk is a step worth taking. Certainly, the children who tend to develop more severe COVID disease are those with those risk factors. But I've seen kids who don't have those, risk factors you think of, like chronic lung disease or other immunocompromising conditions, still come in with severe COVID, particularly our infants who are, their own risk category. And so again, just seeing that, again, it helps me to frame my conversation about the importance of vaccination in this day and age.
Yeah, and I think it's really important for us who are in primary care and may not necessarily work in the hospital anymore, although some of us do, not me, but some of us do, to hear from people like you, Cece, right? That this is still happening. So I'm just glad we're having this conversation. There's one more question that came in about the COVID-19 vaccine, and then we'll transition to talking a little bit about other things that are going on this back to school season, because vaccines has been a big part of what's happening, but there's also other things happening. So this question, and definitely send us more questions if you have them. We'll have time at the end. Melissa, maybe let's go to you. So can you talk about rates of myocarditis after COVID-19 vaccination in the current environment? Is there anything new there, and what's sort of the recap of what we know? And this commenter is reminding us that the reconstituted ACIP, the Advisory Committee on Immunization Practices to the CDC, is bringing this up again. They are meeting later this week, as some of you, or most of you probably know, and parents are asking. So what's the latest, Melissa?
Sure. So just to kind of remind everybody what happened. So when we first rolled out the COVID vaccine and we were giving 2 doses quite close together because we were in the middle of a pandemic, we were trying to get everybody vaccinated and protected as fast as possible. There were some cases of myocarditis, particularly in young men. Once that was picked up and the vaccine started to be spaced further apart, we really rarely ever see that happening. But what's more important is COVID itself causes myocarditis. And so a unvaccinated person getting COVID is much more likely to get myocarditis than a vaccinated person from the vaccine. If that makes sense. So not vaccinating is actually not protecting against myocarditis. It's actually potentially putting your child more at risk of getting a COVID infection and getting myocarditis. I don't know if Cece, you have anything else to add to that.
No, I was just going to say that is exactly it. Again, my bias is because I'm seeing these children in the hospital. And even this past month, I was treating a child who was coming in with COVID-related myocarditis. So she had COVID infection and developed myocarditis in that setting. So we definitely see that.
It's so important to know, I think, Melissa, as we counsel, and Cece, as we counsel families, right, that the vaccine was spaced out after this big push to get us all protected. And now we're not seeing, we're rarely ever seeing myocarditis cases related to the vaccine because of this, because the monitoring system, right, worked. And we went back and looked.
And I think just to the monitoring system, so there are those of us in Columbia who are kind of the lead up this, are part of all of that monitoring at the time. And it really did show how well the vaccine safety surveillance system works in the US. We have an incredibly robust system with multiple levels. I think people are aware of theirs, obviously, which is the reporting that gets done, kind of passive reporting. But there's also VSD, the Vaccine Safety Data Link, which is these usually managed care organizations with a lot of EHR data and kind of looking for any kind of signal. Then there's the clinical cases. So we here at Columbia are a clinical immunization safety assessment center for CDC. So if cases come in to CDC, if a physician or has a question, and at that time, as these cases started to come in, there's a lot of looking at what happened, trying to figure it out, and really like real time work by CDC, who really are amazing people. I want to say to kind of figure out what to do. Let's space out the vaccine. That really did take care of that issue. So I think I also want to talk to families, try and reassure families that that it really is also showing our vaccine safety system at work, how fast that was picked up, and that there are a lot of eyes on this vaccine, on all of our vaccines. There's a sort of constant looking to see, because everyone who works in vaccine safety we want to know, right? If there's an issue, we want to know, we want to be able to take care of it and to tell families about it. So I kind of usually add that piece to it when I'm talking.
Yeah, of course. We had a question come in that asked, where can we see that data about decreased rates of myocarditis over the past years? Is there a site to view the data that can be shared?
I will look. Let me look right now so I can find something. Otherwise, we can try and get it out to everybody.
Yeah, perfect. And then, okay. Okay, so some of these other questions get to things that we had already planned to talk about. So hold tight for just a second, and we will have additional time for questions at the end. So let's transition a little bit again. Keep sending us your questions, but let's transition to some of the other things that are going on this back to school season, because there are new policies in place, especially in New York City. Amanda, one of those things include new cell phone bans in school, unrelated but very much affecting our families. Schools are implementing this all kinds of differently, right? But I'm wondering if you can walk us through how you're discussing these new policies with families.
Yeah, absolutely. So New York State has implemented a new cell phone ban that really is bell to bell. So start of the school day to end of the school day, cell phones are not to be used throughout the course of the day. And this is backed by a lot of good data. So the AAP actually supports cell phone restrictions to some extent within the school system, because when looking at schools who have implemented some cell phone restriction compared to schools that have not, we've seen that there's been improved focus, improved test scores. There's also been a lot of data to support that increased time, especially on social media platforms for adolescents, is linked to adverse mental health outcomes. So we know that kind of being thoughtful about cell phone use and media use is really, really important in our children and our adolescents. And so schools adopting some of these policies are really in an effort to get children to be able to participate, to not have fear of embarrassing themselves or having things recorded. These are all anecdotal pieces that I've heard from families, and I have a family also in the education space as well. And really being able to interact with their peers and not be limited by their screens. That being said, as a parent who just sent a child to school for the first time in the early space that my child does not yet have a cell phone, I understand the fear of not having instant access or instant communication with your child. And so a lot of the talking that I've been doing with families is really just getting to know your child's school, getting to know who's there, understanding their communication plans. If you have a concern, who do you reach out to? Do you know who that person is? Do you have your child's school phone number saved into your phone? What are the best modes of communication, and vice versa? I think it's really important to talk to your child if they have a concern, they're not feeling well, something's going on, that they can talk to other responsible adults in their life to escalate their concerns, so that there is a bridge to communication between child and adult, since that is definitely a very valid and understandable concern.
Yeah. No, amazing. And I think, we're going to see how this plays out, right? But I think it was an important step to take. My one follow-up question for you is, how are you telling families to prepare for those kids who are used to using the phone every day? Sometimes even I think to pass time if they're bored, right? But I think for some of our teens, it's almost like to calm down in some ways, to sort of relax. So how are you talking to families about finding additional ways to do some of those things?
Yeah, it's a really good question. I think part of my strategy has really shifted, honestly, to really being more preventative about having conversations with families of even younger children about when they're planning on introducing phones and what their plan is as a family for how to engage with screens as a whole. And really being really thoughtful about setting some sort of boundaries and agreed upon boundaries about phone time and media time. Because I think if you really get to it from a preventative approach, then it's much easier to have those conversations going forward. That being said, if I do have a family where the adolescent is like used to being on the phone all the time, it's really talking to the family about really and the child about what other strategies, what things do they do to help de-stress, and how do we lean upon those other activities or calming things that they do, listening to music, journaling, whatever it is, connecting with peers that they could be doing as an alternative when they have their boundaries surrounding media time.
Yeah, of course. Melissa, you have firsthand experience with this as a parent. I wonder if you can share how things have gone.
So Amanda and I have kids at the opposite end of the age groups of her. Tell just starting the school process. Mine just graduated from high school. Yith is laughing because I've talked about how my teenager was not so happy with this past year, there being no cell phones in school. But I actually think it was, I think, an important step. I think in that case, really, when you're talking about teenagers, you really, for their school, it was part like a break from social media, right? So you can kind of think and learn and not be sort of worried about that. But I think it was also to get kids to put their phones down and interact with each other. So that they at lunch, at recess, at free periods, that they were doing all the things that we used to do when we were in school. And so I think there are so many pluses to a cell phone ban per se. I think it's wildly unpopular among teenagers, and so I think having that conversation about like, well, this is some of the reasons why it's helpful, and then sort of, but then also say, look, I know it's hard. And I know that you may be unhappy about that, but that's okay. And those are the rules. And, we're going to follow the rules in school. So kind of explaining, but also being supportive that it is hard, but it is a hard change for
Yeah.
them.
Yeah, I have to tell you, if someone took my phone all day, I don't know that I'd be very happy. And I think sometimes putting
Right. Exactly. Right. Well, how would we feel about it too? So
yeah, putting ourselves in our kids' shoes, right? And trying to equip them with tools and skills, as Amanda mentioned, and as you mentioned, Melissa, how we're going to cope with the change, right? Knowing that it is a change. Cece, to go back to you, one of the things that I've seen change a lot, and it gets back to the first half of this webinar, is return to school policies, right? Speaking of policies, after viruses and illness the kids catch in school. It seems to me as a pediatrician and as a mom, right, that things have gotten stricter and that perhaps that was a response to the COVID-19 pandemic and they're starting to relax a little, but not quite to levels before the pandemic. So just give us the recap. In general, when should we keep a kid home and when can we perhaps push back against some of these strict policies?
It is a really great question because it has felt a bit like a moving target. And certainly with the onset of COVID, those rules were very stringent. And again, the goal was to protect everyone. And so, in that setting, that's what we were seeking to do. And so certainly with time, that guidance has loosened and become more relaxed. But the goal is still the same, thinking about, how do I best care for my child who is sick, protect others around them, but also make sure that they're able to get the education that's really important to them and the socialization and all of those experiences that are also important to their development. And so I think really where the shift is coming or where we may be settling out is using fever as the big marker or the big indicator, and symptom improvement, not symptom resolution, but symptom improvement, to be your marker for determining, is it okay for my kid to go back to school? So from a fever standpoint, really looking at, has my child been fever-free for 24 hours without needing to take medications to lower their fever? So they're not taking ibuprofen, they're not taking acetaminophen, they're fever-free on their own for 24 hours. We know that, the fever response really is the body's way of responding to pathogens invading. The body responds by raising that body temperature. And so using that as a marker that things are kind of calming down is helpful. And then the other piece of it is, yes, symptom improvement. Once the fever has dissipated, the child's symptoms, they won't be gone. They're still likely going to have their cough, their runny nose. That takes a little while to go away. And so I think that really is a great opportunity to teach your child or to reinforce with your child good respiratory hygiene. Make it fun, make a game out of it. How do you cough into your elbow or into a tissue? Make it competitive about, as soon as you use a tissue, throw it away, who can do it the fastest. And then the basics, hand hygiene, washing your hands, using hand sanitizer after you've coughed or sneezed, or after you've blown your nose or gone to the bathroom. And really with the goal of helping your child really think about, how do I keep my friends healthy too? I know that I didn't feel great when I was sick. So how can I help my friends stay healthy? And that's a really easy way to do it. And then lastly, if your child is able to, and they still are having, a fair amount of respiratory symptoms, considering having them wear a mask when they return to school. Again, just with that goal of protecting others around them. And so it's always going to be that balance, but I think fever is going to be kind of that big determining factor as we move forward.
Yeah, I love that way to frame it with kids, especially young kids, right? I didn't feel very well when I was sick. How can I keep my friends from getting sick? Susie, I want to make sure that I'm understanding you correctly. But once the fever has resolved, right? They're not requiring ibuprofen, acetaminophen to control that fever, and assuming that kids feel well enough to participate in school activities, to play, to eat, to stay hydrated during the school day, a cough shouldn't really keep them home, and neither should a runny nose, correct?
Agreed. Correct.
Yeah. And I think schools have different policies in terms of requiring letters and notes and things for clearance. I don't know that there's very much that we can do as parents on the parent side if that's a requirement that the school has implemented, and it does vary from school to school. Is that also your perception?
That is it. I mean, it's certainly, I think, something where you can talk with the school about it, especially as we get more data about kids returning to school safely. But certainly, if it's your school's policy and they have a fairly strong stance on that, it will be more challenging.
Yeah, and I think a lot of parents have become very savvy about using things like telemedicine for those types of requirements. But just to plug that we do have the ability to clear for school via telemedicine without having to be so disruptive to everyone's day, right? And add travel. Susie, we also had a question that came in about instructions to patients regarding quarantine after testing positive for COVID. Knowing that the CDC has had many different variations on length of time, what is the latest and most up-to-date recommendation?
That also is very much so a moving target. Historically, we've thought about, 5 days as being that window. Earlier today, I was looking on, just to see kind of New York City, New York State, what was the guidance in New York City, really is using fever as the marker of when it would be safe to return. Again, with that additional guidance, still wear a mask when you're around other people, even when you're deaf or best, especially in those first 5 to 10 days after infection, with the goal of protecting others around you. So that is also shifting. And I think that as we move forward, we will see the response to COVID looking more like other respiratory viruses.
Fascinating. So right now it's really fever. Like if your fever has resolved and okay, and you're feeling
For
well
24
enough.
hours. So fever is
Right,
all
24
hours later.
hours.
The other thing that I think has actually been helpful, as Cece mentioned, is that the CDC guidance doesn't really think of COVID different other respiratory infections because people aren't necessarily testing. So in your head, you can sort of think of it the same. There are some times where there will be no fever. So then it's really about, or is the child, if you're expected, feeling better? And is it 24 hours from when you started feeling better? We all sort of know, like you wake up in the morning, you're like, I'm better. And then, then you look on the day and you're like, well, I definitely wasn't better. And that's where that 24-hour window is really important to make sure you really are getting better. And then and then as Cece said, still taking the precautions, not to infect your friends in school, or your colleagues at work,
Yeah.
even though you're feeling better.
Another question that came in is whether there's any utility on retesting for COVID after you've had an illness where you tested positive, knowing that you can remain positive for quite some time. So is there utility to retesting?
No, there isn't. Once you've had that positive test, you know that you have COVID. And exactly as you said, we know that sometimes those tests, because they're PCR tests, so they're picking up bits of the virus, can be positive for extended periods of time, even after you're feeling better and well enough to return to school, to work. And so really it will be symptom-based criteria to help determine, can I go back to a public congregate setting?
Yeah. Definitely keep sending us your questions. We do still have a few minutes. Amanda, I wanted to go back to you. We've been talking a lot about respiratory viruses and respiratory season. We talked about new policies, again, because they're new, right? And we're just sort of adapting to these things. But I wonder if you can also remind us of the things that we shouldn't forget, the things that are good practices for kids to stay healthy, stay in school, be able to learn and thrive every year, regardless of what the respiratory season and the new policies look like.
Absolutely. And I know we're a few weeks into school at this point, but my general counseling spiel for the last month or so has really been about getting back to routines, making sure that we're on a good sleep schedule, making sure that we're getting adequate nutrition. It's really easy over the summer to kind of slip on the schedule. And then those first few weeks of school can be really challenging and a little bit distressing in terms of getting everyone back into the routine of a day-to-day school environment. It's also now is the time for back to school meetings. So knowing what your child needs, how they're doing in school, making sure you're getting to know their teacher. Is their IEP up to date? Do they have all their school physical forms in on time? Do they have, if they have any medical conditions, their emergency medications available at the school with the emergency medication plan? Are we making sure that their vision, hearing, everything else is screened and up to date? They have their annual physical and they're in good shape before heading into the school year. I'm looking at all of those things as we're going into this school year month.
Yeah, it's a busy season, not just for illnesses, vaccines, and all of those things, but yes, making sure that every child has whatever it is that they need, as a very unique individual that all our children are, to thrive and learn in school. There's a couple more questions that came in the chat. What is the current recommendation about Paxlovid for adolescents with COVID-19? Cece, maybe we'll go to you for that one.
Yeah, so the recommendations are still the same, for our adolescents 12 and over who are presenting with mild to moderate COVID, particularly if they have risk factors that put them at risk for severe COVID. Paxlovid is a good outpatient option. It's an antiviral medication for treatment of COVID-19.
How soon does it need to be started, Cece?
As with anything, in a perfect world, the sooner the better. You really want to, as that viral load is going up, you really want to hit it hard and stop that process. And really that's going to help the recovery phase. So there is no too soon to think about it. But typically within the first 5 to 7 days of illness.
And what are the conditions that would put a teen at high risk for developing severe COVID that should make us say this teen is a good candidate for Paxlovid?
Yeah, so it's going to be, the same high risk categories that we think about when thinking about vaccinating this age group as well. So those who have respiratory conditions like asthma or chronic lung disease, obesity, congenital heart disease, those who are immunocompromised. So all of these put our patients at risk for potentially developing severe COVID. And again, the goal is to keep them out of the hospital. I love seeing kids, but I don't want to see them here. So anything we can do to keep them out will be good.
Yeah. The other question that came in, Melissa, maybe we'll go to you for this one. Will all insurers in New York State fully pay for the COVID-19 vaccine?
I think it's an excellent question, and I think so the New York State has recommended or highly asked of all insurers to cover, but we all know that insurers coverage can be different. So I would say this is honestly like a day by day situation. So it's probably best if it's a family that they're checking with their insurance, whether it's being covered or not. I wouldn't want to give a blanket statement saying that it's all covered. Obviously, if a child qualifies for VFC vaccine, then, at least as of right now, right, the New York City and New York State guidelines, what we're following for the children, for the vaccines for children program. But for commercial insurance, it's always best to check with the insurance. Wish I had a better answer. Maybe next week I'll have a better answer. But
Yeah,
we are right now.
moving targets. The other question I had for you all, and again, people who are still on, we still have a couple of minutes. There, as you know, have been recent changes in how we talk about vaccine mandates for school. And one state, Florida, has moved to say that they will no longer require vaccines for school. To the best of my abilities, as I understand this, so far it was an announcement that they're going to move toward doing away with vaccine mandates, but they haven't actually done away with vaccine mandates. But gets to the larger, I think, changing conversation that we're having about vaccine mandates for schools specifically. My question to you all is how can we frame perspective for families on this? Because I think some of the conversation is becoming, more parental autonomy, parental rights. How do we bring the conversation back to health, and how should we be having those conversations with our families? And maybe I'll go to you, Cece, first.
It's definitely challenging. As a parent, you want to do what's best for your child, who is your heart. They're the child that's right in front of you. But I think, again, there's always going to be that balancing measure. We are all members of a larger community, and that's a really beautiful gift to be able to be a member of a community and to think about how can I care for this community as a whole. And really, when we talk about vaccines, it's dual purpose. It is protecting your child. And we have so much data that shows that vaccines do just that. They protect your child from these serious infections. But then we also know that if you have a group that's getting vaccinated, that provides larger protection for the community as a whole, particularly when we think about the most vulnerable in our community, those who may not be able to be vaccinated for a reason, those who may be immunocompromised and so at higher risk for these infections. And so I think really just appealing to what I think we all share, which is seeing kids stay healthy and framing the conversation in that way, I think is the most important thing.
Yeah. Amanda, sometimes I think part of what gets lost in that conversation is what else is happening in our offices when kids come to see us just because they need vaccines, right? Sometimes that is, in many ways, what gets kids in our door, right? Like through the door to see us. But there's so much more that happens in our offices. Give us some of that perspective.
Absolutely. It's something I worry about too. Fortunately, there's no changes to our vaccine mandates at the time. But one thing I would be worried about if I were a provider practicing in a state that is changing those mandates is our children going to be coming in to see me on their regularly scheduled well child care schedule? I think a lot of parents say, okay, we're due for vaccines and that's when we're coming in. But really, at a well child care visit, we're checking growth development. We're covering the full gambit of their medical needs. And so we want to make sure that we're keeping up with that schedule while still promoting vaccination at each visit, for sure.
Yeah. And Melissa, lastly, for you, I think, we're talking about this in some ways as if it's a new thing, this vaccine mandates. They're really not new. Give us some of that perspective.
Sure. Yeah, so vaccine mandates have obviously been around for a very long time, and there's very strong evidence that they work. We do know that states that have stronger vaccine mandates, which means more limited exemptions that are granted, really do have lower rates of vaccine preventable diseases. It's interesting. They asked a number of like public health practitioners what was like the 10 most important discoveries of all time. They did like in the 1980s, they did it again in 2000, and it's always vaccination is always the top of the list because we know that vaccines protects lives, done, like full stop. And so I think on one hand, people do want to protect the community. What we say to families is, and there's actually, we've done some work with them, what messaging they liked. they actually like the messaging that like we're all healthier when everyone's vaccinated. So it's not necessarily like I'm vaccinating my child to protect you. It's like it's actually healthy for my child when we're all vaccinated together. But families, as Cece said, they're trying to do what's right for their child. There's so much information out there. They're very confused. And so I think if we provide the information that's necessary and needed and answer their questions and come from a place of understanding, but that also choosing not to vaccinate is still an active choice they're making, and that actually can put their child at risk. So it actually isn't necessarily safer for their child not to vaccinate their child. All of many of the diseases that we vaccinate against, we are seeing, right? There's measles outbreaks all the time. There's pertussis outbreaks. There's mumps outbreaks. There's many of the different things. It's not that long ago, maybe 15-ish years ago, we had a Haemophilus influenza outbreak. I think that was started in the Pennsylvania area. So it's important for us to, I think, to remember that the reason how we got to where there were vaccines and vaccine mandates were because there were diseases that really can make kids very, very sick, and in some cases, unfortunately, kids can die from them. And so being able to kind of have that conversation with families will answer the questions that they have.
Yeah. I'm so grateful for that perspective. I'm so grateful for all of your perspectives this evening, for your time this evening. We will be sending out a recap email with some of the links we talked about to sign up for a conference. We did get a question about the cost of the conference. It is not free, but it is extremely affordable compared to other conferences, especially for general practitioners. So very, very affordable, though not free. And we will be sending out more information about that, more information about the one, and many other things. Thank you all so much. Thank you to our panelists for joining us this evening, and thank you all who joined this evening as well. And we'll see you next time. Take care, everyone.